what will be your preferred option for this patient? She received letrozole and progressed after 4 years. Fulvestrant plus palbociclib or ribociclib, fulvestrant plus abemaciclib, exemestane plus everolimus, or capecitabine. I don't know if you can vote here. We will wait 3 or 4 seconds. So more votes.
Can you move back the code, please, that we need to scan?
Okay.
Yeah. So everyone needs to scan this in order to participate.
Okay. Okay, so this is a patient who received and progressed on letrozole. So I think that it makes sense to continue with endocrine therapy. Why? Because she's asymptomatic and she's not in a visceral crisis. I think that all of them, fulvestrant plus palbociclib and ribociclib is a good option. Fulvestrant plus abemaciclib is a good option. Exemestane plus everolimus is a good option. However, in my opinion, the toxicity profile and also the activity we observed with abemaciclib or ribopalbo is better compared with everolimus. Also, we have to take into account the improvement in survival with the Monarch 2 data. So basically, the patient received abemaciclib plus fulvestrant. She had grade 1 diarrhea, no other toxicity, neutropenia grade 2. And you can see here the beautiful partial response the patient had with the combination of fulvestrant plus abemaciclib. Lung metastatic disease, great response. Also, when we look at the axilla and the mass of the breast, also we have a great partial response. Last patient is a 72-year-old woman. She received neoadjuvant treatment, doesn't matter, because of a large tumor, ER positive, PR positive, HER2 negative, Ki67, 35%, received radiation therapy and letrozole. So after 3 to 4 years, supraclavicular lymph nodes, increase in the tumor marker, liver metastasis, mediastinal metastasis, and cervical lymph node metastasis. We have a biopsy, ER, PR positive, HER2 negative, and also an estrogen receptor gene mutated. Which is your preferred option for this patient? Please, there is a mistake here. OS, which is ovarian suppression, is not correct. So it is fulvestrant only, fulvestrant palbo-ribo, fulvestrant abema, CAPE, or NAP paclitaxel. Please vote now. So 3, 2, 1, 0. Okay, so I think that, again, I think this is a patient who have received previous endocrine therapy. She's progressing on adjuvant treatment, so Monarch 2 patient. Remember that in Monarch 2, we observed an improvement in overall survival with abemaciclib. Basically, it's interesting for those patients with liver metastasis and primary resistance. So I think this is a patient for abemaciclib plus fulvestrant, not for chemotherapy for sure. Even having liver metastasis, it is preferable to use endocrine therapy plus CDK4/6 inhibitor. Very quickly, the patient developed once again diarrhea, grade 1. Remember that grade 1 diarrhea is a common adverse event with abemaciclib, and the patient had again a beautiful partial response in the liver. Basal, 3 months after, very similar, but 1 year after, more or less, beautiful partial response. The patient was at that time on 15 months with abemaciclib plus fulvestrant. So my friends, in the clinic, we have different groups of patients. Patients with a very good prognostic factor, patient who is very sensitive to endocrine therapy. This patient did not receive ever endocrine therapy or the disease-free interval after the end of endocrine therapy to the metastatic time is more than 3 or 4 years, asymptomatic, non-visceral metastasis. Patients with sensitive endocrine breast cancer with a disease-free interval more than 12 months, but less than 3 to 4 years. Patients also usually non-visceral metastasis, minimal or not symptoms. Patients with moderate sensitive disease, patients with a disease-free interval lower than 12 months, patients sometimes with visceral disease, no or minimal symptoms, patients with very aggressive disease, visceral disease, symptomatic, patients who received and progressed on adjuvant treatment, and of course, patients with visceral crisis. In my opinion, all these patients in the visceral crisis should receive chemotherapy, but all the others should receive endocrine therapy plus CDK4 and 6 inhibitor. Maybe abemaciclib should be used preferable for patients with aggressive disease, and all of these 3 agents could be used in patients with less aggressive disease. So I would like to conclude. So first, remember that all these agents are impressive. We have a clear revolutionary change in our clinical practice. 2, the clinical benefit, even in overall survival, is not conditioned by toxicity. 3, and there is a question, do we need overall survival to give these drugs upfront with the data we have today? I think the answer is no. I think that the data we have with progression-free survival, time to disease response, overall response rate is good enough for me to consider these agents as a standard of care. And 4, all these agents are great, but all of these agents are different. We have to decide one of other based on other of our preferences, but clearly, at least for more aggressive disease, abemaciclib maybe is the preferred option. Remember, my friends, and this is my last comment, the beautiful adjuvant data from Monarch E we had at ESMO this year, so maybe the future in the metastatic disease will change. Thank you.
Thank you very much, Professor Cortes, for this very clear presentation and spot on the time. I think we should take Q&A questions now before Professor Marwan and Professor Alaa and Kandil presentation. So I'm waiting for question, but I will start with asking you, what's your take on Parsifal trial?
Parsifal. Well, that's a great question. I think that you all remember the Falcon study. In Falcon, fulvestrant was better than anastrozole with a hazard ratio of 0.80, 0.79. But for those patients with non-visceral metastasis, the hazard ratio of fulvestrant over anastrozole was in the range of 0.60, more or less, 0.59. So in Parsifal, we compare in the first line setting, letrozole, palbociclib, fulvestrant, palbociclib. The data were very similar between both of them. Fulvestrant was clearly not superior to letrozole plus palbociclib. And even in patients with non-visceral metastasis, the hazard ratio was near to 1, which means that, in my opinion at least, there is absolutely no reason to go to upfront fulvestrant if we give a CDK4 and 6 inhibitor. So my preferred option is aromatase inhibitor plus CDK4 and 6 inhibitors in the first line setting. And
do you base one of your questions, the ESR, based on the, is it called PADA-1 trial, where they check the ESR? Would you put this in your clinical decision if a patient's got ESR1 mutation?
That's a lovely question. So, okay, so it is true that we usually do not test for the estrogen receptor gene 1 mutation upfront. This is something we usually look at that after second or third line to look at different mutations. And also we have to take into account that although the data seems to be better in favor of selective estrogen receptor degradators or moderators compared with aromatase inhibitors if the mutation exists, it is true that we do not have prospective data that have been validated. Having said that, if I know that a patient does have an estrogen receptor gene mutation 1, I would prefer fulvestrant compared with aromatase inhibitor. But usually I do not have this information up front. So yes, if I have the data, I would prefer fulvestrant.
I'd like to welcome, I've just noticed Professor Nadia Saghir have joined us. Hello, Professor.
Thank you. Thank you. Hi, Javi. How are you?
Hi, Nadia. Hi, my friend.
Hi, everybody. Can I make a small comment, ask you a question? We commented about Farsiba and the use of fulvestrant in first line. Well, Mona Lisa 3 trial had patients in first line and beyond first line, and had survival advantages. So in some cases, I'm not totally against using fulvestrant in first line.
Yeah, okay, so yeah, you're right. But in Mona Lisa 3 and in Monarch 2, it is true that in Mona Lisa 3, fulvestrant plus ribociclib is better than fulvestrant. I completely agree. However, fulvestrant plus ribociclib has not been compared with letrozole plus ribociclib. So my point here is that if you use fulvestrant, of course, you have to combine with the CDK4 and 6 inhibitor. That's very clear. But if you go for the CDK4 and 6 inhibitor, whichever it is, palbo, ribo, abema, I think that fulvestrant or letrozole are both very similar in activity. So of course, I feel very comfortable with fulvestrant and ribo or whatever. But I think that I feel the same comfortable if we use, instead of fulvestrant, we use letrozole. Also, a very important point about the activity of CDK4 and 6 inhibitor in other tumor types. There is a question here. So in triple negative, there are not data, to the best of my knowledge, in the clinic, but there are some preclinical data showing that in patients with luminal-like subtype, triple negative tumors, maybe CDK4 and 6 inhibitors might work. I proposed a clinical study to Lilly about 3 or 4 years ago with abemaciclib in triple negative breast cancer, androgen receptor positive tumors. But unfortunately, we didn't conduct that study. In HER2 positive disease, there's some beautiful data about the use of palbociclib plus Herceptin in Herceptin pretreated patients. And it seems that when we have a luminal-like, again, HER2 positive disease, CDK4 and 6 inhibitors might work. So yes, there are some preliminary data showing that in other tumor types, if luminal-like tumors, it might work.
Great. So again, I have last one question. I would like to know your opinion before we move on to the next step. What about the same scenario where liver metastatic but in premenopausal? Mona Lisa 7, where does it come in?
Yeah, no, I think Mona Lisa 7 is a great study, and study just designed for pre or perimenopausal women with a beautiful improvement in progression-free survival, overall response rate, and overall survival as well. So I think that if you have a patient with, again, I think that we have beautiful data and beautiful studies from all these drugs. And I think that although Mona Lisa 7 was conducted with ribociclib, I think that it also works for ribo, palbo, or abemaciclib. And the other way around, Parsifal was conducted with palbociclib. But also I think it could be also thought about the other CDK4 and 6 inhibitors. So in premenopausal B-cell metastasis, for me it is very clear. Zoladex or goserelin plus letrozole plus a CDK4 and 6 inhibitor. That's what I would suggest.
Okay, thank you so much. I guess with the time, we're going to have to move on to Professor Alaa.
Thank you.
Kandil. Thank you very much, Professor Cortes. So Professor Kandil is a clinical oncologist at the Department of Clinical Oncology and Nuclear Medicine at the Alexandria School of Medicine in Egypt. He's author and co-author of more than 45 articles and currently is a principal investigator of 7 studies. Professor Alaa, thank you very much for joining us, and I cannot wait to hear your talk.
My presentation is a short one, actually, more or less to illustrate the point of using ABIMA. Do I have control on the slides, right? Doris?
Yes, you have.
Okay. Okay. Just moving on. Okay, my patient actually is 32-year-old, and that was at the year 2009. And she's gravid at 3-para-3 with negative family history for breast and or ovarian cancer. Her past medical history was relevant. She had positive nursing with no use of contraceptives beforehand. I'm sorry, I moved the more than one slide. Okay. Okay, presented with a right lower outer quadrant breast mass, August 2009, that on a true cut biopsy proved to be ER strongly positive, PR moderately positive, negative HER2 by immunohistochemistry. Her tumor size was 3 by 2.5 by 2 centimeters with a Ki67 of 20%. This is the copy from her pathology report saying exactly the same I said in the last slide. So she had a full metastatic workup, including CT, chest, abdomen, and pelvis bone scan. That was negative. She had an infiltrating duct carcinoma grade 2, and this is post-operative, with 2 out of 23 positive lymph nodes with negative extracapsular extension, and she had positive lymphovascular invasion. Again, this is her pathology, copy of her pathology report. Now she went on the conventional adjuvant systemic therapy. She received AC ×4, docetaxel ×4 cycles, went on to receive locoregional radiotherapy. That was followed by 5 years of tamoxifen, then ended on the year 2014. So up till now, there's nothing. And she's been on follow-up for another couple of years, where in June 2016, she had mildly elevated CEA 15.3. She was NED, no evidence of disease, and her 15.3 was repeated every 2 to 3 months, showing a slow increase. At that time, she had a PET CT that showed no evidence of disease. So she was assured and kept on regular follow-up. At January 2017, she complained of an anterior chest wall pain. On a bone scan, she had 2 small rib active lesions. Her CT, chest, abdomen, and pelvis were still negative. And at that time, CA 15.3 was 110. So she received Femara with LHRH agonist and was very well controlled till December 2017 with stable CA 15.3. And I did lose her for almost a year and a half or so till March 2019. And she mentioned that she was taking her treatment regularly. I mean, Femara or letrozole plus LHRH. Now she's coming on March 2019 with severe back pain, and a PET CT and MRI proved positive metastatic disease, and that was bone, liver, and lung mets. She was started on urgent radiotherapy, and at that time, we had enough data, as already Javier mentioned, that a CD46 inhibitor could be an option in those patients with other options for sure. Anyway, she was started on abemaciclib, the usual 150 BID with an LHRH. She was still hormonal profile of a premenopausal. In addition to zoledronic acid. Can I move? Yes. Okay. Sorry, the slide is not moving. Okay, and this is the PET scan, March 2019, when she presented with the severe low back pain and proved widespread metastatic disease at that time. I consider that a high disease volume with a very aggressive nature to start with. It's taking too much for the slides to move. Okay, and this is actually only 3 months after being on abemaciclib plus LHRH, and you can see actually the very good partial response that this patient had. This patient is a teacher, by the way. She's very active, and she's still working. And fortunately enough, a couple of months even before that PET-CT, she could come back to her normal life, going to work, taking care of her kids, and other life style that she used to have. And that was June 2019. I don't know what's happening with the slides. I'm trying to move this slide on. Okay, the patient remains on that treatment. She had dose reduction twice for a grade 1 to 2 diarrhea, the usual loperamide, but actually was not really bothering that patient. It was very well controlled. And her last follow-up was August 2020, something like 4 months or a couple of months from now. She has stable disease with no specific complaint, and she had a recent PET-CT that showed exactly the same picture as the June 2019, where her CA 15.3 was 55. So this patient with abemaciclib, a CD46 inhibitor, and LHRH plus zoledronic acid was very well controlled. And what's really important for that patient is the quality of life, and that the very rapid response that she had after something like less than 3 months, which actually goes well with the curves we see with the use of CD46 inhibitors. I guess that was my last slide. You did edit it, right? Okay, now the floor is yours, Mr. Chairman.